Now, a fine reference that I use, and I suspect you've been using it also during your time here with our coursework, is the textbook that has been produced by AAOS called Community Health Paramedicine. Are you familiar with that text? Have you familiarized yourself with it? It's a fine reference. And chapter 21 in this text covers in detail many pharmacological agents that I will not to some degree cover this evening, but it's a great reference, and you can certainly utilize this as you do your work in the area of community paramedicine. And I would also suggest to you that you consider adding an app to your smartphone. And what I have been using up to this point to assist me in reviewing medications that I'm being presented with in my patient care is Medscape. Have you heard of Medscape? It's a free app, and you can download it into your phone system, and it gives you really excellent reference material for medications you may encounter in your work in the community in dealing with folks who have chronic illnesses. So I would highly suggest that you consider adding that app to your smartphone as a reference as you do your work in the area of community paramedicine and community health. Now, what I'd like to... All right, terrific. Thank you, Al. Okay, so the first topic of discussion then this evening is going to be reviewing with you the issue of diabetes mellitus. Now, let me ask this. Why do you think we're going to cover diabetes tonight? Why is that so darn important, do you think? Any ideas?
It's a very common disease, and it affects other diseases.
Absolutely. It's a very common chronic disease. Unfortunately, as we get older, many of us deal with that. And it has implications related to other disease processes that are associated with it. And if you reflect a bit on that, diabetic patients have significant problems with atherosclerosis. They prematurely develop coronary artery disease and heart-related issues. They end up prematurely developing stroke and issues related to central nervous system problems. Unfortunately, it can lead to renal dysfunction issues, visual dysfunction issues, and peripheral arterial disease, which leads to peripheral neuropathies and various other things. So diabetes is certainly an important chronic disease that we have to begin to deal with aggressively for the patients that we're working with in our area of community medicine. So I'm going to be reviewing with you then this concept of diabetes mellitus. Now, some of this I'm sure is review for you, but I want to just re-emphasize some of the principles that we look at when it comes to diabetes as we get into the pharmacology. Now, the definition of diabetes is pretty straightforward. It's a group of metabolic diseases characterized by an elevated blood sugar, hyperglycemia, and this can be secondary to defects in insulin production, or it can be related to how insulin acts at the peripheral tissues, or it can be a combination of both of these things. So physiologically, this is the definition of diabetes. Now, there are two types. Type 1 is related to an autoimmune process where the body attacks its beta cells embedded within the pancreas, totally destroys them. Might be related to viral exposure, unclear, can be some family history associated with it. But when people develop this problem, they end up totally deficient in insulin. And the treatment for that is an insulin type of product, and we'll review that as part of our work together this evening. Now, as one becomes older, not uncommonly, and perhaps has some weight-related issues, the second type of diabetes may present itself in our patients. That's type 2 diabetes. Type 1 has an absolute deficiency in insulin. Type 2 diabetics have a relative deficiency in insulin. So they differ within those parameters. Now, back in 2010, which is 10 years ago, worldwide, if you looked at the occurrence of diabetes, over 220 million folks were contending with that. And unfortunately, it's getting worse. And it's getting worse now in third world countries, Asia and Africa. Rates are going up there 2 to 3-fold, probably related to some degree to the lack of exercise for these folks. There's a genetic factor probably involved in that, and some dietary issues also could very much be a part of that. Now, if we as providers are assisting our healthcare team in deciding, does this patient have diabetes, and if so, to what extent, we may be asking you to assist with doing some testing to get a handle on that for the team. So if indeed we ask you to go and visit someone in their household, and we say, you know, just catch a blood sugar on these people. Now, we call it casual glucose value. It doesn't matter if they're fasting or not. Get a casual value. And if that value comes back exceeding 200 milligrams per deciliter, by definition, that person probably is a diabetic. Now, they may not have other symptoms of diabetes. They may not be urinating a lot. They may not be drinking a lot of water. They may not be losing weight. But if you have that casual plasma glucose concentration exceeding 200 milligrams per deciliter, by definition, that patient is a diabetic. Now, you can ask the patient, listen, I'm going to be visiting you tomorrow morning. Can you fast for 8 hours before? And if you touch a blood sugar after that fasting 8-hour period of time and that blood sugar exceeds 125 or 126 milligrams per deciliter, by definition, that patient is diabetic. Now, I'll tell you, if you talk to the American Diabetic Association, they're going to say, we're going to even get tighter on that. If you end up with a blood sugar fasting of 100 or more, that by definition potentially is a diabetic patient. So they're really ratcheting down that fasting blood sugar result. And you'll be seeing that in some of the work you're doing with your healthcare team. Now, there may be on occasion where they'll actually have your patient load up with sugar, 75 grams of sugar. So it's a drink, dissolve it in water. And then 2 hours later, you catch a blood sugar. And again, if that exceeds 200 milligrams per deciliter, by definition, that also is that's 2-hour postprandial blood sugar. By definition, that's a diabetic as well. Now, as we then make the diagnosis of diabetes, and we know this patient has this as a problem, periodically we may be doing a test called the hemoglobin A1C test that gives us a handle on how well the patient is dealing with their condition. How well are they following the diet recommendations? Are they exercising? Are they taking meds appropriately? And so we'll ask you to catch that hemoglobin A1C. It's a glycosylated hemoglobin is what it is. It tells us over a 3-month period of time how well the patient has been handling their diabetic condition. And you kind of like to see it around 6.5 to 7. If they're handling it well, that's kind of what you see. That indicates to me that their control is pretty good. I tend to be a little more flexible in the elderly. Once you achieve the age of 65 or 70, I'm pretty flexible in having that hemoglobin A1C around 7, maybe 7.5. You don't want these elderly patients to be so tightly controlled they drop their blood sugar, have a syncopal episode. See what I'm saying? So I tend to be more, give them a little more slack when it comes to that hemoglobin A1C as they become older. Now, when it comes to management of diabetes, we're going to be talking about medications this evening, but there's much more to handling diabetes than meds. And we actually have what we describe as a glycemic control initiative. We have therapeutic aims that we hope to achieve in handling diabetes. And those are listed here. For sure, it is important if your patient is diabetic that they handle conditions that are associated with diabetes aggressively. It's very important that you control obesity for these folks. Hypertension aggravates atherosclerosis, got to handle that. Hyperlipidemia, cholesterol issues, triglyceride issues, you got to handle that, excuse me. And certainly if they've actually had a heart problem, if they have ischemic coronary artery disease, you have to aggressively deal with that problem as you deal with the diabetic condition as well. Now, in your review of chronic illnesses, as a review, you certainly know already that diabetics end up with end organ failure problems, especially if their control is not good. And they typically can end up with kidney-related issues. You got to keep a handle on that. They have heart-related issues. Of course, they prematurely develop coronary artery disease. You got to be vigilant about that. The small arterial vessels in the retina, back of the eyes, can become atherosclerotic. They can rupture. You can end up with blindness related to that. And then also the small blood vessels, the capillaries that feed nerves in the peripheral part of our bodies can at times be compromised in diabetics, and they end up with peripheral neuropathy. They end up with problems of peripheral neuropathy that certainly can be problematic in dealing with their management as well. So when it comes to the strategies, the first thing you do as a provider of care for this diabetic patient is to make sure that they're following their diet appropriately. They need to achieve a medical nutrition therapy that's prudent for them. This is something that's usually developed in partnership and conjunction with a dietitian, and it demands cooperation of the patient and usually the patient's family as well. And so each patient individually needs to have a medical nutrition therapy prescribed for them. Now, many patients feel that if they're diabetics, they got to stop taking in carbs. And that's not true. They need to continue to take in carbs, but they need to be what we call complex carbs, harder to break down. And if you look at the number of calories per day a diabetic patient is asked to consider taking, it's 1,500 to 2,000 calories per day. 50% of those remain carbs, complex carbs, 20% protein, 30% fat. So for the body metabolism to function properly, you need to have that type of caloric breakdown on a daily basis for folks, diabetic or not. Second major therapeutic strategy is to have the patients exercise. They need to exercise. Aerobic activity increases insulin sensitivity in the peripheral tissues, and it also promotes weight loss, which is useful in diabetic conditions as well. So you need to have good diet. They need to exercise aerobically on a regular basis. And okay, so the patient then is doing this. You're the community paramedic going to visit them. You're going to check them again after they have been in this therapeutic regimen for a month, maybe 6 weeks. And then you determine, is this doing sufficient approaches for the patient in management? And if that's all they need to control their diabetes, great. Catch a hemoglobin A1C, it's down there around 6.5 or lower, that's good. So you just keep them on the focus. Keep up with the exercise, follow the diet, you're looking good. And you reassess them every 3 to 6 months with a hemoglobin A1C to see how they're doing. Now, there will be time, however, when this is not enough. And it's at this point then you need to go ahead and begin management with medications. So we're going to be talking about pharmacological therapy then at this point. And we already covered the fact that if you are a type 1 diabetic, by definition, you need insulin. Oral agents and other agents that we'll review here this evening are not going to be useful for someone who is a type 1 diabetic. They need insulin. If you're type 2, however, which many of our elderly are, and many folks perhaps who have obesity issues are dealing with. They certainly may do well by following the first two therapeutic approaches we talked about, diet, exercise, and adding to their treatment plan an oral product, maybe 2 oral agents. You got to be watchful though, because as you know, diabetes can get worse over time. It is potentially a progressive disorder. And ultimately, you may reach a point in your handling of your diabetic's case that oral agents just aren't going to cut it, and you'll need to add insulin to the treatment plan as well. And we'll cover what type of insulins might be available in handling diabetes here this evening as part of our work together during the first third of our presentation. So let's talk about the meds, okay? Let's talk about the meds. Let me suggest to you that one of the probably the first oral agent that was useful in handling type 2 diabetes was a product called a secretagogue. A secretagogue. And what they do is increase insulin secretion from the beta cells within the pancreas. There are several different agents that are useful in that setting. We'll review that in just a little bit. But that was the first class of oral agents then that were useful in handling type 2 diabetes. Now, there are other oral agents that actually reduce glucose production in the body. We'll cover those as well. We have some agents that actually decrease glucose absorption from the GI tract. We'll cover those agents as well. And we have some agents that actually increase insulin sensitivity at the peripheral tissues. And we'll cover those agents as part of our work together this evening also. Now, most recently, there has been a fifth agent that has been useful in dealing with diabetes. It's a unique class of medication called the SGLT2 inhibitor class, sodium glucose cotransporter type 2 inhibitor agents. And it's interesting. What these agents do is they affect absorption of sugar in the renal tubules. That's how they work. They do not allow glucose to be reabsorbed through the renal tubules. And those agents are unique. They were just recently developed over the last 5 years, and we'll cover those just briefly also at the end of our review of oral agents this evening also. Well, let's talk about the secretagogues at this point. And, you know, I bet you folks have seen this in your work as 911 responders. The very first group of this first class of oral agents called the secretagogues were the sulfonylureas. Does that name ring a bell for you? Sulfonylureas, are you familiar with those agents at all? Maybe not. They were one of the very first agents developed. Let me tell you this. The first group that came on board probably developed in the mid-60s, early 70s. They were called first-generation agents. And you may encounter some of these agents with some of your elderly patients who were reluctant to make change. I'll give you some names: oronase, dimilor, tolinase, diabinase. That's chlorpropamide. The trade name is diabinase. And you may, in particular, in some of your elderly, see when you do your med review with them that they continue to take chlorpropamide. And again, that trade name is diabinase. It's a fine product. It's an inexpensive product. Been around a long time. Problem is, though, it stays in the bloodstream a very long period of time. Its half-life is very long. And if you end up with a patient who takes too much of it, they can have prolonged hypoglycemia, which becomes a problem for them. But that is an oral agent, a sulfonylurea, a secretagogue, that you still may see as a first-generational product. Now, in the 70s and 80s, sulfonylureas were more fine-tuned developmentally into what we call the second-generation group. And those are agents that have fewer side effects. Their half-life in the bloodstream is shorter, so hypoglycemia is less of a problem. And what you might see there are trade names like Diabetic, Micronase, Glyinase, Glucotrol, Diamacron. Okay, those are second generation sulfonylureas secretagogues, but they also very effective in stimulating the beta cells in the pancreas to produce more insulin. Okay, so that was the very first group of secretagogues that we had available to us as providers of healthcare in handling a type 2 diabetic's pharmacological needs. Now, most recently, within the last 10 to 15 years, there has been a second group of secretagogues that are non-sulfonylurea agents. And those are listed on the right side of our graphic here. Glitinides is the technical name for them. And the trade name Prandin, Starlex, that's what you might encounter when you do your med review. These are medications that are secretagogues also, but they're very short acting. They're in and out of the patient's bloodstream, very short period of time. So the chances of them developing a prolonged hypoglycemic episode by administering these products is minimal. So these products we actually administer right around mealtime. They take it just before they eat, maximum benefit during the time the food is being ingested and absorbed, and it's out of the bloodstream in a very short period of time. So those also are secretagogues, newer type, the glitinides. You may find those as you do med review for some of your patients as well. So each of these products stimulate insulin secretion, and they interact at the sodium-potassium pump and the cell wall of the beta cell. Now, you may recall when you had your pathophys presentation, we reviewed with you at that time the importance of having this pump at the cell wall to allow proper equilibrium of cell function. Well, in the beta cell's function to produce insulin, these particular meds affect that sodium-potassium pump on the beta cells to cause the beta cells to produce more insulin. We already talked about the fact that these first generational products have a longer half-life, so you got to be watchful. When you use them, you have a higher incidence of hypoglycemia, which can be a problem. The second generational products in this class, fortunately, do not have that type of side effect. So we're trying to switch our elderly patients away from the first generation to the second generation sulfonylureas because of that benefit. There are some side effects. I do not expect you to remember these side effects. What I want you to do, though, make sure you have a reference. When you're doing these pharmacological med reviews, and you're going to be asked to do that for every patient, it's important for you to have access to a resource that will allow you to determine what are the interactions that occur that increase hypoglycemic effect or decrease hypoglycemic effect of these products. So have that reference available. The glitinides act in a very similar fashion to the sulfonylureas. They affect that same pump. It's an ATP-sensitive potassium channel pump. They work in the same fashion on the beta cell. That's how they work. They do give you a faster onset of action. They have a shorter half-life and a shorter duration of action, which is a benefit. So you give these products just before mealtime, and the beauty is they don't cause a prolonged hypoglycemic event. So they're very, very useful in that type of setting. The doses tend to vary from one product to another. And again, you can determine what dose is appropriate depending upon the type of medication that is being administered and review the patient's medication list. Keep in mind that many of these products break down in the liver, and then those byproducts are secreted out through the urinary tract, through the kidneys. So many of these products, if you have a patient that has a compromise in liver and renal function, tend to break down these products more slowly, and they can accumulate within the tissues of the patient's body, which can be a problem. So keep that in mind as you deal with patients who have chronic illnesses of any type. Now, second class of medications that I find very useful in our patients' needs are what we call the medications that are that promote sensitization of how these products function at the patient's peripheral tissues. And one of the meds in this class would be the biguanide class. Now, the technical name for that is metformin. That's the chemical name. The trade name is glucotrol, or glucophage, I'm sorry. The trade name is glucophage. It's been around a very long time. And the beauty of it is it has very few problems secondarily. Doesn't cause hypoglycemia. It does not cause problems with syncope or altered mental state. And it has a mechanism of action that's fourfold, which is beautiful. It reduces hepatic gluconeogenesis. So the liver can produce glucose on occasion. This medication helps to prevent that. It also promotes, it sensitizes at the peripheral tissues the intake of glucose to provide energy to muscle and to those peripheral tissues. So it's a sensitizing agent, which is good as well. It also reduces absorption of glucose from the GI tract. So you take this, it kind of sits in that bowel area in the GI tract, and you take in simple sugars, and it doesn't allow them to be absorbed. So it has that nice secondary benefit. And then lastly, it has an antagonistic effect on plasma glucagon. And you may recall glucagon is another hormone produced in the alpha cells of the pancreas. And that, when it gets into the bloodstream, causes blood sugar to rise. So this is an antagonistic product to the development of that condition. So it has 4 mechanisms of action that are really top-notch. You administer it in doses of 500 milligram strength. So you usually start off with a 500 milligram dose, take it once a day, see how the patient does over a period of a week to 10 days. You then double the dose if necessary, and you can increase the dose up to 1,000 milligrams twice a day if you need to. And you then can see what kind of positive effect you're getting by seeing what the blood sugar level is doing with response to that. Now, one of the darn side effects of this product is it causes some GI disturbance, and some people cannot tolerate that. It can cause nausea, anorexia, loss of appetite. It can cause belching, kind of a sense of gassiness. Some people end up with significant loose stools from it. And it's because of that, they just simply can't tolerate it very well. And that is the one drawback related to this product. Also, it has a unique characteristic that if it's administered at a time when the patient, for example, is becoming septic, or the patient is going to go in for a radioisotope study, it can actually lead to the development of lactic acidosis if it's taken within 2 days of those events occurring. And so you got to be very vigilant about this product in that setting, causing potential lactic acidosis. The beauty of it is it does not cause low blood sugar. It does not cause weight gain or weight loss. So it's beautiful in that setting, and it's inexpensive. It is cheap. It's been around a very long time. So it is very useful in obese diabetics, and it's useful in what we call a pre-diabetic state. We sometimes will prescribe this for someone who it looks like they're going to be developing diabetes. They haven't reached the parameters that we talked about with blood sugar analysis, but you're concerned. You can sometimes put them on this product in a pre-diabetic state, and it may curtail the actual development of diabetes. It is broken down, however, in the liver and in the kidneys. And so if you got a patient that has chronic illness involving these organ systems, remember, the dose has got to be limited in these people. Also keep in mind that it can promote lactic acidosis when taken in a setting of sepsis. So you got to be real vigilant about that. It tends to accumulate in peripheral tissues if the heart is not beating forcefully enough. So if you got somebody with CHF, it can accumulate in the peripheral tissues, and this can be a problem. And last but not least, if you got some patient going in for a radioisotope study, say a renal isotope study or whatever, with contrast, you got to stop this medication within two days to prevent lactic acidosis from developing those folks. Okay, so those are the secondary problems with the biguanide product, metformin. But it's a nice product. It's useful in certain settings. It's inexpensive. And the beauty of it is it has very few side effects outside of the GI tract. There is a third group of products that sometimes are useful. We in this country don't use them very often. They're called the alpha glucosidase inhibitor products. Those are listed in our graphic here. The trade names would be Precose and Glycet. These products sit in the GI tract. So you take these products in, they sit in the GI tract, and what they do is they do not allow sugar to be absorbed into the bloodstream. They just sit there. Now, part of the darn problem is, though, they also cause belching, gas production, feelings of distension, sometimes diarrhea, and again, kind of like metformin. Because of that, people don't like to take it. And so the bottom line is we tend not to use these products very much in this country. But if you look at, say, third world countries and European countries, to some degree, they are using those products in those settings. Okay? Now, fourth class of meds, recently developed, quite effective, are the glitazone products. The glitazone products. And those are listed here. Now, I tend to add these products as kind of my third or fourth med to add to a type 2 diabetics condition. I do so because they have major side effects. These are sensitizing agents, by the way. They work kind of like the biguanide. What they do is they go to peripheral tissues, particular muscle tissues, and they attach to the cell wall of these muscle tissues, and it promotes then getting sugar into the muscle for energy. They're sensitizers, so they work beautifully in that setting. However, they have side effects, and they're expensive. And the problem is they can lead to toxicity within the darn liver, which can be a problem. So right now, we only have a couple of them that we use in this country, Avandia and Actos. So if you do your med review and you run across one of these two products, okay, you know this is one of these glitazones. It's a sensitizing agent. It decreases insulin resistance in the peripheral tissues. That's how they work. But you got to keep in mind, if you got a liver problem, you got congestive heart failure issues, if your kidneys aren't working right, it can accumulate. And you can end up with a problem and toxicity because of that. Also, if you have a pregnant gal who you're working with, and some pregnant gals will actually have what we call diabetes that occurs with pregnancy, gestational onset diabetes. You can't use these products in that setting. They typically do best with insulin therapy because they usually need it during the pregnancy, and once baby comes, they no longer need that product. And some of these oral agents can go across the barrier, the placental barrier, get into the baby's bloodstream, and then that's a problem, you see. So we don't utilize this product in gestational onset diabetes because of it. Now, some of the newer products that are really exciting to consider we're going to be reviewing those next. And what the first group are injectable products. They're the exenatide products. And they actually mimic endogenous incretin. Incretin is a hormone produced by the stomach. And it's unique because this hormone is only produced by the stomach when carbohydrates are in the stomach. Incretin is produced by the stomach at that point. Now, these products extend the release of those products. And that's the beauty of it. It stimulates glucose-dependent insulin release. That's how it works. So it doesn't cause hypoglycemia. Now, these are injectable products. These are injectable products. They attain some modest weight loss with some of these agents also. Some of them are touted for weight loss and so on. The first agents demanded a twice a day injection. And you may have heard of this. Byetta was one of those products. And then the second product developed in this class was a once a day injection called Victoza. And now most recently, what's really being touted are once a week injectable incretin mimetics. And you maybe have seen these advertised on TV. Trulicity. Have you seen Trulicity advertised? Have you seen Tanzium advertised? Have you seen Ozempic advertised? These are all once a week injectable exenatide products. And they're beautiful because they may cause non-glucose dependent insulin release, and they do not cause that. They are glucose dependent insulin releasers, and that's the beauty of how they work. Okay? So you may be seeing more of that in the short and long term as well. Now, there's some oral agents that work in the same fashion. They affect that same product. That's the DPP-4 inhibitor products. And the names of those products, these are tablets. They take them orally. Galvus, Januvia, Onglyza, Tradjenta. Again, I don't expect you folks to remember this, but what I am going to ask you to do is be able to, when you review the meds of your patient, go to your resource, look these products up, and over time, they will stay with you. You see what I'm saying? They will stay with you. So keep these products in mind when you're doing your med reconciliation. And then, of course, that last group of products that I reviewed with you already are those unique agents that actually work at the renal tubular level, the SGLT2 inhibitor products. These are oral medications, and they work by preventing the kidney from resorbing glucose. That's how they work. They're unique. And those are a fifth group of oral agents that you may be seeing more of in the work you're doing with your patients. But these are spendy. You know, some of these newer agents who do not have generic versions are spendy. And we try not to, economically, we're very focused on our patients' needs to be able to pay for these things. And so you got to keep that in mind. All right. Okay, so we covered a lot of meds. And what I'd kind of like to do now is summarize, perhaps, how do we treat a type 2 diabetic recently diagnosed? All right, how do we do that? Well, we have determinants that we look at to select the product. And I like to look at three things, folks, three things. Is it an efficacious product for the patient? Does it fit their needs well? Is it a safe product to use for them? Is it safety certainly needs to be considered, and how spendy is it? How cost? You got to be cost effective in handling some of these products. I mean, some of our poor elderly folks in particular who are living on Social Security, if you're prescribing a medication that cleans them out every month, that's not going to work. And so you need to prescribe medications for them that are cost effective as well. So whenever you choose a med of any type, but in particular in a type 2 diabetic, efficacy, safety, cost, very important. Example, okay, so, you know, the secretagogue sulfonylurea are useful in certain cases, but if you got some patient that's got a really high blood sugar, not going to probably help very much. And especially if you have a patient already overweight, one of the side effects of these sulfonylurea products is they can gain weight. And so, you know, it's not that med isn't going to work too well for them. Also, say we got a glitazone product. And, you know, if you got a patient that really doesn't have a problem with insulin resistance yet, administering this product, which is spendy, is probably not going to help them. It's not going to be beneficial for them. So you kind of sort through these various parameters as you make a choice individually for your patient. Side effects, you know, you need to weigh what is the positive with the negative side effects. Hypoglycemia can be a real problem with especially long-acting sulfonylurea products, and also weight gain is especially problematic in some of these patients as well. You got to think about that. Cost, very important. Meds that have been around for a long time that have generic versions tend to be less spendy. And if they're effective, great. Let's go ahead and prescribe them. Newer products that have no generic base tend to be more expensive. That's a problem. And in that type of setting, you got to think about, can my patient afford these products or not? And if you can't, there's no sense prescribing them. Okay? So let's look at a patient, newly diagnosed, type 2 diabetic. Parameters we look at. Here's what we hope to achieve for this patient. We'd like to see a hemoglobin A1C in a young person 6 to 6.5 or less. Elderly patient 7.5. Fasting blood sugar 100 to 120, depending upon the age of the patient. 2-hour postprandial 140. And the thought is you want to make sure you got tight control, but you don't want to be so tightly controlled that the patient has hypoglycemic episodes. You got to be watchful of that. So the initial intervention is your team. You're a member of the team. You need to then provide education for your patient, diabetic education. You cover medical nutrition, weight control, exercise. All of these things have to be part of your management. If that's not then getting the job done, then you consider adding a medication orally for management. And as I suggested, I usually will start out with an inexpensive product with fewest side effects. Metformin may be useful in that setting. So move ahead with that. I then recheck my patient after a period of time. Now they are suggesting within a 3-month interval, what I would say a new diabetic, you're going to be checking them probably every 4 to 6 weeks to start with. And you're going to be checking to see, okay, what's their weight? You look at their diabetic sugar diary. How has that been? You look at also at that point at hemoglobin A1C, and that can give you a bead on how well controlled that patient is doing with their diabetes at that point. Now, if the goals aren't met, however, then you need to consider adding a second oral agent, folks. A second oral agent. And in that type of setting, you follow the same plan. You reassess again in another 4 to 6 weeks. And if that's not getting the job done, okay. So you've then done due diligence. You've got them on a diet. You've gone over exercise with them. You've got them on 2 oral agents, just hasn't cut the mustard. You need to go back to your team then, probably your physician or nurse practitioner or PA, and say, Doc, this isn't, it doesn't appear this is working. And at that point, then it'll need to be decided, do we add insulin? Do we add insulin to the treatment plan? Or if you have someone really severely diabetic, they may need a consultation with an endocrinologist. You know what I'm saying? So you have a plan of management that you can follow for your type 2 diabetic patient, well referenced here. Does that look reasonable to you folks? Your thoughts on that? Reasonable at this point? Okay. I think it makes sense in handling in this fashion. Now, okay, so you may reach a point then, folks, where those oral meds just are not enough. And of course, if you have a type 1 diabetic, they're gonna need insulin. And so in a setting where you've got a type 2 diabetic, poorly controlled, needing insulin, okay, we're going to have to prescribe that. And also type 1 diabetic, we need to prescribe insulin. So in that setting, we're going to review with you now the various types of insulin available in handling your patient's needs. Now, these are some other conditions where you find insulin especially being useful. Poorly controlled type 2 diabetic, secondary diabetes. Say you got a patient on high amounts of steroids, for example. They may need insulin for a short period of time. Gestational onset diabetes, pregnancy, they're going to need insulin. You treat that with insulin. You may have a patient who is stressed. So you got a type 2 diabetic doing okay on oral meds, but they end up with an acute MI or a stroke, or they end up with a need for surgical intervention. This is highly stressful on the patient's body. It triggers a significant inflammatory response within the patient's body. And that may necessitate, blood sugar goes up in that setting. that may necessitate then insulin being added to that treatment plan for that patient. Okay, so let's talk about the types of insulin at this stage. The first type that I suspect you're going to be seeing quite a lot of in your work with your diabetics is this one, the rapid acting type of insulin. And if you're looking at, what are these things? Well, insulin aspart is actually a product called Novolog. Insulin Lispro is a product called Humalog. Insulin glucine is actually a product called Apidra. Okay? And those are short-acting types of insulin. So bottom line is you give them a shot of this stuff. The onset is within a 1 to 2 hour window. And the duration of action of this in the bloodstream is about 4 to 6 hours. Okay, so this is a rapid acting type of insulin. Now, there's a second type. We describe that as a short-acting insulin. Common name for that is regular insulin, can be inhaled insulin, is now useful also. And the beauty of that is kicks in 2 to 4 hours, on board for 6 to 12. So you kind of can get a feel. If we give a shot of this, it's going to kick in 2 to 4 hours, it's going to be on board for up to 12. So that's the short-acting type of insulin. Third type, intermediate acting, lente insulin, NPH insulin, and what that means is that's the neutral protamine hagedorn. That's what NPH stands for. Again, interesting, don't have to memorize that, but that's an intermediate acting type of insulin. So you give a shot of that stuff, onset 3 to 8 hours, duration of action 12 to 20. 12 to 20, okay? The fourth type is what we call long-acting insulin. And there are 2 of those long-acting insulins listed here. Insulin glargine, which is Lantus, and insulin detamir, which is Levemir, is the trade name for that one. Okay? So these are the 4 types of insulin available for our patients to utilize depending upon what their needs might be. Now, once you get your patients in a routine, and you've got a kind of a bead on what their insulin needs might be, you can then sometimes actually give shots that mixes a couple of these insulins. And this is an example, you can mix 70% NPH and 30% then of the Novolog. If you got a patient that is stable and you know what their insulin needs are. But you do that after they've been on it for a while. Okay? So this is a graphic that kind of shows you what we talk about time frame wise in administering insulins. And you can see, that the curve of A, that's what we would describe as a short acting type of insulin. The B then would be more of an intermediate product response over time. And the C then would be that long acting insulin that gives you that long acting effect over an extended period of time. Okay? Now, insulin is a fine product. Keep in mind, though, you give too much, it drops your blood sugar. You give it in the same spot recurrently, it's going to cause what we call a breakdown of fatty tissue nearby subcutaneously. That's lipodystrophy. So the thought is, if you're going to give a shot of insulin sub-Q, you got to move around. You give it in different parts of the body in order to make sure that you don't cause this as a problem. And in days past, we used to use insulin that we got from animals, from pigs, from cows, and so on. We don't use that anymore. But in that setting, you could actually trigger an insulin allergy for some people when we were administering it in that fashion. Now, when it comes to a need for insulin, we usually start out by giving what we call a sliding scale of insulin to get a handle on what the insulin needs are of a patient within 24 hours. And then after that, we can then begin to administer what we call a basal bolus insulin amount, depending upon what that first 24 hours of blood sugars is showing us. So how do we figure that out? Well, here's the deal. Say I have a 70 kilo patient. Baseline, you're thinking this patient is going to need over a 24-hour period of time, 0.5 international units of insulin. Okay, so you got to administer this insulin in this fashion over a 24-hour period of time. Now, keep in mind, if the patient is stressed, they got concurrent disease, MI, if they have had previous high blood sugar levels, they've dealt with ketoacidosis, they've taken steroids, you're going to have to modify your approach here. What we're talking about is a patient who has none of these secondary issues that you're getting started on insulin for management. Okay, here's a graphic that shows it all, tells us all how to handle this. You figure out what that total amount of insulin is going to need, that patient needs over a 24-hour period of time. 0.5 international units per kilo. 2/3 of that you're going to administer early in the day before breakfast, because the patient's going to be active throughout the day, needs it throughout the day. 2/3 of that insulin dose you're going to administer prior to breakfast. And of that, 2/3 of it should be intermediate or long acting, and 1/3 should be short acting. Makes sense. The intermediate long acting give you coverage throughout the day, 8 to 12 hours. The short acting covers you for that immediate bump in blood sugar being impacted by breakfast, you see. 1/3 of that total insulin dose you would consider administering before the evening meal time. Of that, 2/3 would be intermediate long acting to help the patient get through the night with their insulin needs. And 1/3 of it then would be short acting to take care of the glucose bump that occurs with the evening meal. You see? So that's kind of how you figure it out. And then you decide, okay, then you do blood sugar checks. And you figure out, well, you know, this patient probably needs more short acting, say midday and later on, because their blood sugars are higher. You see what I'm saying? But this it gives you a baseline to work from that's very, very effective. These are examples of how you might use this calculation in administering various insulin types. So look at the top one. Okay, you got a patient there that you figured out has a certain amount of insulin needs for 24 hours. You give them an initial bump of regular in the morning. You cover them then 2/3 with NPH, gets them through the day. By evening mealtime, you give them another bump of regular, and you give them then a bump of intermediate acting NPH to get them through the night. You see? Bottom figure, same thing. At bedtime, you're giving them a bump of intermediate acting insulin to get them through the night into the next morning. And then you give them at breakfast time a bump of regular, lunchtime, dinner, a bump of regular. You see? So in that particular patient's needs, you handle those blood sugar results by administering insulin of this type in this fashion. All right, well, once you get your patient who's diabetic in good control, then it demands that we make sure they stay in good control. And how do we do that? Well, we need to monitor them. Our team needs to watch over them closely. And that means that the patient needs to learn to do blood sugar checks. And they need to develop a diary that you can review on a regular basis with them. That helps to sort out how well they're controlling their condition each day, you see? So they need to be able to do that. You need to be able to do that, and you need to assist them in getting that done. In the old days, we used to do urine tests. We don't do that anymore. It's got to be a blood sugar test that we look at. And then we fold into that hemoglobin A1C assessments every 3 to 6 months. This is done routinely now in our diabetics to give us a handle on how well controlled their condition has been within that period of time. It gives us a good lens that we can use to review with them how well their control has been. As a part of this, patients need to know how to do their own blood glucose checks. They need to understand that they will have to have hemoglobin A1Cs tested at least 2 to 4 times a year. For sure, they need to stay on track with their diet. For sure, they need to have an exercise regimen embedded in their treatment plan. You need to continue to educate them about the importance of this. It is prudent also that perhaps once a year they see someone who can look into the back of their eyes and make sure that they aren't developing problems with those retinal vessels that can lead to blindness. Really important that you check on a regular basis patients' skin areas where there is pressure. And in particular, if you have a diabetic patient that has peripheral neuropathy and they can't feel very well in their feet and lower extremities, you got to actually look there and see if they're developing pressure points, skin breakdown, ulcers that can lead to recurring infections that can be really a problem for patients. You got to do foot examinations on a regular basis. Need to periodically do a urine test check to see if the patient's spilling protein. If they're spilling protein, that indicates their kidneys are not functioning well. And diabetic patients showing this can indicate that they have a nephropathy developing that you need to really be watching over closely. Very important that you control other risk factors for developing atherosclerosis in these folks. They should not be smoking. They should be watching their diet closely. They should be refraining from cholesterol and triglyceride products in their diet. They also should have a blood pressure that is appropriate. Hypertension can aggravate atherosclerosis. So in particular in a diabetic, that blood pressure needs to be properly managed. You need to be an educator for your people. So you're working as a community paramedic, community paramedic technician, community EMT. You need to educate your people. You're spending an hour with them with your assessment. You can educate them about what hypoglycemia is, how you treat it. You're reviewing their blood sugar diaries with them and reviewing that with them. If they have hypoglycemic episodes, how do you handle that? You review management of that. And certainly when it comes to episodes of syncope or problems of hypoglycemia, caution them. If these episodes are problematic, they should not be driving a car or handling heavy machinery until you get those things properly managed with them.